Anemia is one of the most common problems in pregnancy. We all know that there are different kinds of anemia, and in anemia we have several decisions to make: how to investigate, when to transfuse, when to give parenteral iron, and how to manage hemolytic anemias in pregnancy. To sort out these problems, we have an excellent speaker. He is none other than Abraham Ittyachen, the HOD and a professor in MOSC Kolancheri. Over to you, sir.
Thank you. At the outset, may I thank the scientific committee of APA Kochi for having invited me to deliver this talk, especially Professor Gilles George. Now, speaking about anemia, I think this is one gray area where both the obstetrician and the internist, as the general physician, treats. Probably the obstetrician would have a better role or a wider role than the physician, and only in some selected areas are we called. So I intend to give an overview of this subject. With the time allotted, I wouldn't be going deep into the subject. Now, Dr. Gilles, he actually told me to stick to these topics, these questions, which you probably have seen in the brochure, but I will be going a little out of this, where I'll be dealing a little bit of the physiology and also a little bit of the biochemistry, so that it will probably make you understand it better why this topic is important. Now, this is how I'm going to approach. As I start from the beginning and I go towards the end, in between I will be covering each of them: how to investigate, when to give parenteral iron, what are the safest iron, when to transfuse, and finally a bit about hemolytic anemia in pregnancy. So let's start with a little bit of physiology. And before that, the first question: how to investigate. Now, if you look at this image here, on the y-axis, you see the blood volume, and the x-axis, you see the gestational age. And the graph here, it shows how the volume expands across the trimesters. It increases most in the second trimester, plateaus towards the third trimester, and goes down. This has got a physiological importance. Actually, the reasons behind this has already been dealt with in the morning session. So, frankly, my sessions are a little more easy because a lot of the questions which I have here already been answered in the morning sessions. And from here, you will know that in pregnancy, the volume actually increases by approximately 50% than the not pregnant stage, and that has got physiological implications. And regarding why this happens, I am not going in detail, but just to complete the picture, why this is because it is to meet the metabolic demands of the enlarged uterus, provides abundant nutrients, expanded intravascular volume, safeguards some mother against adverse effects, so and so. So there is a physiological reason why this happens. Now, if you look at the actual expansion, both plasma volume and erythrocyte. Initially, there is more of plasma than erythrocytes, and late in pregnancy, the volume expansion decreases while the hemoglobin mass continues to increase. And it's thought that it is due to an increase in erythropoietin level. Now, why the plasma volume increases? In the morning, we had an excellent talk where this topic was dealt with. And if you look at these patients, they would have a mildly increased reticulocyte count. And ultimately, if you look at the plasma and erythrocytes, both have increased, but the volume of plasma is slightly more than the expansion of the hemoglobin. Now, because of the lag of erythropoiesis in comparison with the more dynamic plasma volume expansion, alternation of such parameters happens. That is, there will be a decrease in hemoglobin, there will be a decrease in hematocrit, and there will be a decrease in RBC counts, and that's what you call as the physiological anemia of pregnancy, which I am sure the obstetricians are very much aware of. So the question arises, how do you differentiate between physiological anemia and true anemia in pregnancy? And I think this will sum up it all. if you look at the physiological anemia, hemoglobin, there is a fall, but not to the point of definition of anemia in pregnancy. While in the pathological anemia, there is a definite fall as per the definition, which I will come to in the next slide. If you look at the hematocrit, it comes to the lower range of normal. Here it goes below normal. And probably the tests that are given here, those will clinch the diagnosis, whether it's a physiological anemia or pathological anemia. The RBC indices, they'll all be normal here, but here they'll certainly be abnormal. The peripheral smear will be normal in physiological anemia. Here, according to the pathology, usually the iron deficiency, you get microcytosis. Then the iron studies in physiological anemia, unless you have inflammation, the ferritin level will be normal. While in true pathological anemia, ferritin will be normal, serum iron will be normal. But if the patient has got an inflammation due to some cause, it may be due to a connective tissue disorder infection, the ferritin may go up, because as you might know, ferritin is an acute positive phase reactant. And response to the iron therapy, that's probably something that is also helpful. Now, coming to the actual definition, which I am sure the obstetricians are already aware, it's defined as a hemoglobin level less than 11 gram. If you look at the CDC definition, they have gone a little more further. The first and second trimester, they have put the cutoff at 11, and in the middle, that's the second trimester at 10.5. The Ministry of Health and Family Welfare of our government, they have actually classified anemia according to mild, moderate, and severe, and probably this is what we should keep in mind, what is severe anemia, because below 7, the entire management changes. Looking at the other cause of anemia, you go into any literature, the most common cause still described as iron deficiency anemia, even in third world countries. I mean, even in the developed countries. Now, if you look at certain areas of the world, for example, in India itself, some areas, helminthic infections are common, malaria is common, but such things are not always given in literature. But that is the truth. Now, what are the investigations? That's actually the question I should answer. That's the first question. Now, with the what we have discussed so far, I think I already describe what's the importance of hemoglobin, hematocrit, the RBT indices, peripheral smear, iron studies, and how they help you differentiate not only in the diagnosis of anemia, but also to differentiate between physiological and pathological anemia. Now, this is also a very important slide. In fact, I found it a little difficult to get this, because if you look at the standard textbooks of medicine, hematology, or OBG, they won't mention the chronological order in which this happened. And also, I always wondered how this happens, and I had to do some research, and I was successful, I should say, and very useful. Actually, if you look at the different indices which I already mentioned, including the ones that are not routinely done, this is the order in which the changes occur to the point where you actually satisfy the definition for hemoglobin. So one of the first changes that occur in blood is a decrease in serum ferritin, and followed by the others. Probably some of them are done only in research labs, but at least for the trainees here, for those people who are preparing for the MD exam, this I think is a very good slide, the chronology of events in a case of iron deficiency anemia. Now, coming to the second question, when to give parenteral iron and how much? Now, let's go back to the basics. If you look at the requirement of iron, folic acid, and B12, the iron requirement goes up to 2 to 3 fold, folate requirement 10 to 20 fold, and vitamin B12 2 fold. The way I remember it is, I usually club both of them together, iron and B12, both of them by 2 fold, and folate 10 to 20 fold. That's the way I remember. Either way, what you have to remember is that there is an increase in physiological demand during pregnancy. Now, if you look at the daily requirement, the WHO, in conjunction with some of other international societies, this is what they recommend: 60 milligram per day of iron and 400 microgram per day of folic acid. And in those countries or states where you have anemia, actually the WHO and even our government recommends you continue iron even 3 months postpartum. But this value is important, because if you look at some of the formulations given brought out by some of the companies, you will understand the importance of this 60 in retrospective. And that is what I had in mind. If you look at the common tablets available, you look at here, the ferrous fumarate, all of them come to close to around 60 milligram of iron. Now coming to the actual question, when to give. Across the different preparations available, oral preparations, I think here probably my obstetric colleagues are more familiar. One of the most important complaints that not only in relation to pregnancy, even for a non-pregnant person, one of the most common complaints with the patient says is that gastrointestinal side effects. We cannot tolerate the drug. So that is actually one of the most common indications for parenteral iron. If you look at moderate anemia and moderate and severe, I already defined in one of the earlier slides as per the definition by the Government of India. In moderate anemia, first trimester, the indications are oral iron not tolerated, non-compliant to oral iron, no improvement in hemoglobin or improvement less than 1 gram after 1 month of oral IFAs, iron plus folic acid, moderate anemia after 32 weeks, and severe anemia that is less than 7 due to iron deficiency at 13 to 34 weeks of pregnancy. What are the safest iron preparations in pregnancy? Now, these are two molecules that have come up, I wouldn't say recently, but they were not there when I was doing my MBBS. Iron sucrose and ferric carboxy maltose. Now, speaking about iron sucrose, it's a non-dextran. I think the word dextran would probably ring a bell in a lot of you because we have used it long time back. It is responsible for a relatively rapid erythropoiesis and quick rise in hemoglobin within 5 to 7 days. And if you look at the expected increase in hemoglobin for pregnant women after 3 weeks, it would probably around 2.5 gram with severe anemia and 1.7 gram with moderate anemia. The way I see it is that I usually take it as 4 weeks, probably slightly more than this. The important thing is, compared to the earlier preparations, you have a rapid erythropoiesis. The next molecule, ferric carboxy maltose, again here at 2 weeks, it is around 1.5 gram and 2.5 gram by 4 weeks. Slight difference. And regarding the two molecules, when I was discussing with my obstetric colleagues, though the literature says that FCM is more reliable, more beneficial effects, they were telling me that most of them use iron sucrose. I don't know about the other people here, that they say it's because it's a little more cheap and you can give it in one dose. So many advantages with iron sucrose. Now coming to the advantages which I just told about ferric carboxy maltose, where it actually scores point over iron sucrose, it can be administered as an intravenous infusion based on the calculated iron requirement with 100 ml of 0.9% normal saline over 15 minutes. The maximum dose per session is 1000 milligram. If subsequent doses are required, you can give it on the 7th and 14th day. And the other advantage is you can give it at the PHC level, but under the supervision of a medical officer. Compared to the earlier preparations like dextran, the side effects are much less, but they are not uncommon. And one very important advantage compared to the older preparations is that a test dose is not required. Now, coming to the formula that we use, the Gansoni's formula to calculate the total iron deficit in pregnancy, 2.4 into body weight into target hemoglobin minus actual hemoglobin plus 500. Weight, the pre-pregnancy weight is taken. If you don't have a pre-pregnant weight, you take the weight of the first visit as the weight and target for a hemoglobin of 11 and allowance for reserve and is 500. I am not sure how many people use this formula. Probably the obstetricians here, especially those who are in the chair, could tell me where you actually use or whether it's solely of theoretical interest. Frankly, I have never used this. Now coming to one of the last questions, when to transfuse. There are several indications for pregnancy: severe anemia in pregnancy, obstetric hemorrhage like antepartum, intrapartum, postpartum, the frank blood disorders like hemoglobinopathy, bone marrow failure, other iron deficiency anemias. I'll be sticking mainly to the severe anemia in pregnancy, and according to the FOXI guidelines, pregnancy less than 34 weeks, hemoglobin less than 5 gram with or without signs of cardiac failure or hypoxia. For pregnancy less than 34 weeks, but hemoglobin more than 5 but less than 7. If there is impending heart failure for more than 34 weeks, less than 7, even without signs of cardiac failure. Now here, what I'd like to highlight is, I am also a clinician, and in the previous slides I have shown values like 5, 5.7, 7, and what is important here is the hemoglobin threshold is not the only criterion. The clinical status matters, and that includes symptoms of anemia, cardiac decompensation, hypoxia, ongoing bleeding, and ultimately what I am trying to imply is it's not 7, the value that matters. It should not be like that, it's 6.9, I won't give blood, let it go below 7. Ultimately what matters is your clinical judgment. If you feel that the patient has got features of hypoxia, cardiac decompensation, is requiring additional oxygen, then definitely there is an indication for hemoglobin, or rather blood transfusion. Coming to the last question, which Dr. Gilles has asked me to answer, hemolytic anemia in pregnancy. Now that's a very big topic. Probably, I think Dr. Neeraj would have been the better person. So I'll only speak about just the broad guidelines. Before that, let us just see what are the hemolytic problems which you see in pregnancy. One is something that got to do with alloimmunization, which you can remember from your MBBS days. The mother is Rh negative. Suppose the baby is Rh positive, what do? I don't have to go into that. And the next one is the pure anemia, the hemolytic anemia of the mother. Here I'm just planning to give you what are the principles in the approach. First and foremost, it should be a multidisciplinary approach. Some of the points which Dr. Neeraj has already alluded to in his speech. It involves obstetrician, the hematologist, the transfusion medicine specialist, neonatologist. Now we have an upcoming specialist, the maternal fetal medicine team. The important thing is the physiology behind that, optimize maternal oxygen carrying capacity. I also have some background of critical care, so I take care of patients in the ICU too. Even there also, what we look at is we don't look at values, we look at the oxygen carrying capacity, which also includes hemoglobin, the partial pressure of oxygen, saturation. So many things are taken into consideration, and depending on that, we decide regarding the blood transfusion. The value 7 is only a guide. By itself, it's not an endpoint. But probably one important thing we have to remember in the background of hemolytic anemia is these patients would have received a lot of blood transfusion, and it's very likely that they would have developed alloimmunization to the minor antigens. So it's always safer to give leukoreducers, that is red blood cells which are irradiated, and absence of any other antigens. At least the antigen should be decreased to the limit possible to avoid reaction. Then, if you look at the management, actually I think for me that's the easiest. Treatment is individualized, and as said by one of the speakers in the morning, corticosteroids can be safely given. In fact, there are a lot of conditions, hemolytic anemia in pregnancy, where we give steroids, and that has to be continued. And supportive therapy. Now, importance of folic acid here is different from the requirement of folic acid in iron deficiency or anemia of pregnancy. In hemolytic anemia, there is a rapid turnover of RBCs. And we know from our biochemistry and physiology days, folic acid is very important for that. So for part of the reason is why folic acid is given here is this. It's not for the anemia of pregnancy, but for an entirely different reason. Iron only if deficiency is proven, because we have a tendency to give iron whenever we see anemia, but in hemolytic anemia you have to be careful. Sometimes the patient's iron stores may be adequate. If you are not careful, we may end up giving too much iron. And of course, the other important thing, like in any case of hemolytic anemia, adequate hydration and urine alkalinization is important, because otherwise we would end up with hemoglobinuria, which we know is toxic to the glomeruli, and it can cause renal failure. So these are in general the general principles in the management of hemolytic anemia. I think that's my last slide. Thank you.
Thank you, Professor Ittyachen, for the lucid and clear talk. Now the topic is open for discussion. Any questions from the floor?
So regarding the FCM, like as a practitioner, I will say like most of the time 1000 milligram will be enough. So usually we don't calculate according to the weight and all that, but if it's indicated, we'll give 1000 milligram and then follow up after 3 to 4 weeks, and then if it required, we repeat.
Yeah, that's what the guidelines also say. And like I mentioned in the beginning, in the introduction, some of these areas probably you are more familiar than us internists because you deal with it more commonly than us.
So one more thing, sir, regarding the first trimester screening for anemia, like always we have confused, like when second pregnancy they came with hemoglobin less than 10, previous pregnancy also is there. There is always a confusion whether to investigate for thalassemia and all that. So is there any role for Menser index? We should all start screening Menser index in the first trimester itself.
Frankly, madam, I am not very familiar with that because usually such things are now dealt by the hematologist. Usually, regarding the things which I mentioned here, the most important thing which I would like to highlight is because that's the problem which we face. When you are given a reference to anemia, is it physiological or it's pathological? And I have already highlighted the points where we try to differentiate between the two. Some of these things you need actually a specialist consultation with the hematologist.
Yes, sir. Very thank you for your very lucid presentation, which has addressed all the specific points mentioned. And just one question regarding the administration of iron, parenteral iron. Is there any specific side effects we should be looked for during the administration
come
of
back to
parenteral
the previous ones, the chances of anaphylaxis and side effects are less. So in fact, most guidelines say that you have to actually give it in the presence of a medical officer under supervision. You don't have to give a test dose, and in the case of ferric carboxymaltose, sometimes you may have problems if you don't flush it adequately. And one more point, what they say is that you should not give it too fast nor too slow. Both of them can produce problems.
Is there any chance of hypotension during iron infusion?
No, with the current preparations, even the literature doesn't say, unlike the previous preparations.
Thank you for the excellent presentation. Actually, it is a very extensive topic, and it requires an orchestrating harmony between the physician, obstetrician, and even surgeon to hit the diagnosis and hit the treatment. That is one aspect. The second point, if the hemoglobin is steadily decreasing, suppose from 16 to 12 rapidly, we need not wait for the level of 11.
Yes,
to evaluate.
I totally agree with you. That's what I told you.
Yes,
Both of us we come from the clinical medicine side.
Okay.
We should always assess the patient clinically rather than blindly believing the investigations. A fall in hemoglobin of 16 to 10 is probably more dangerous than 12 to 10 because the patient is losing a lot of physiological reserve. So probably the clinical judgment is more better than the actual values you see in the lab.
Great. Another thing about the IV preparations, the initial first 20 ml sometimes can be taken as a test dose.
Yes, that's also in some guidelines I mentioned that even for iron sucrose and carboxymaltase you can do that. You don't have to give a test dose as such, but the first few drops can be taken as a test dose.
And one practical aspect I have noticed is that we have to be very careful about the label, about whether it is IM or IV. Sometimes mistakes happen and severe anaphylaxis is possible also. Thank you once again for the excellent presentation.
Thank you, madam.